this session, we're going to focus largely on medicine and medical-related issues. And our first presenter is Dr. Hopkins, who's an associate professor of philosophy at Millsap College. He's going to talk with us about moral disease. So, Patrick, thank you.
Hello, everyone. Thank you. I'm glad that we recently eaten so that no one will be irascible and have to be morally educated to listen to the talk. So I want to talk about the concept of morality and disease. And the framework that I'm going to be using for this is first to talk about the significance of the source of moral cognition and partly about the character of moral cognition. To what extent does moral cognition count as another type of cognition or a special case? Then I will talk about the concept of normality. I will connect that to the concept of disease. And I'll talk about some consequences of looking at things this way. So the first thing I want to look at is stuff that we're all familiar with here, which is the source of moral cognition. At least in a very significant sense, we're getting lots and lots more information that the source of moral cognition is biological. So there's a biological substrate for moral emotions, for what counts as morally salient, for what counts as moral categorization. Now, part of the significance of this is, of course, it is related to a long tradition that may think of morality as more associated with the mental as opposed to the physical. And so this squarely puts it much more in the category of the physical. It also strongly suggests that it is amenable to an evolutionary description, in which case we can think of our moral emotions, or typical moral emotions, as having evolved and therefore being adaptive but not optimal. The second kind of thing that I want to think about is the character of moral cognition. And basically what I want to posit here is that moral cognition is its own phenomenal type, as opposed to some theories of emotions in which they have people have argued that our responses to what we categorize as moral situations are simply applications of certain basic kinds of emotions, such as fear or anger, to certain social situations. And instead, our moral emotions have their own phenomenal quality, so that it is not the case that shame, guilt, pride, regret are simply applications of other basic emotions, but they are their own kinds of emotions. I don't think that this is a crucial part of this outlook, but I think it's a significant part. All right, so if it is the case then that moral cognition, our moral emotions, have a biological substrate and they have their own phenomenal character, then I think we can begin to think about applying the concept of normal and abnormal in a purely descriptive sense right now to what this means. If it is the case that biology is what is generating in large part our moral cognition, and if it has an evolutionary background, then we can think of certain types of moral emotions and certain types of stimuli that trigger moral responses as being species typical. So there's a statistically normal species typical profile for human beings for their moral responses and moral emotions. This would certainly be the kind of thing that would conflict with older ideas of there being not just relative moral truths, but actually completely relative moral frameworks. And it certainly conflicts also with the idea that everything is simply environmentally determined. Now, if it is the case then that we can think of a biological, evolved, species-typical set of moral emotions and moral salience factors, then we can apply statistically the idea of there being normal and abnormal versions of these. So that this is a purely statistical notion right now. One of the things that I've been thinking, though, is that if we think about simply as a kind of a categorical exercise, in what ways could moral emotions in particular be normal or abnormal? There may be certainly more, but I thought about three types of abnormality, three categories of abnormality. The first one I'll talk about is moral emotion response. This essentially refers to what stimuli trigger our moral emotions and our subsequent behavior. Now, in terms of how this might be abnormal with regard to a statistical notion of species typicality, it might be the case that you would have an abnormal responder. So this would be someone who has a moral emotion triggered by atypical stimuli. So I'm thinking as an analogy, and certainly these are not perfect analogies, as an analogy. So this one might be hypersensitive. So something that is not normally allergenic or not normally causing a certain kind of respiratory reaction, other kinds of reaction, does cause such a reaction in a person who is allergic. So it might be the case, for example, just in reading various case studies of people with obsessive compulsive disorder, for example, that sometimes they will have what is a normal emotion, but it will be triggered by an atypical stimulus. For example, for some people with OCD, when they discover that, read in the newspaper that someone has died peacefully, but someone they did not know, they may have guilt triggered about that, even though they have no connection. Intellectually, they know they had no causal relationship to the death, but they will experience guilt. It might also be the case that we have abnormal non-responders, in which case what would be a typical normal moral emotion would not be triggered by the typical stimulus. So, as an analogy, you might have type 2 diabetes. The body is not responding to the presence of glucose by producing enough insulin. In this case, it might be something along the lines of antisocial personality, in which someone does not experience any sort of empathy with an image of someone experiencing pain. Or it might be the case that someone experiences no startle reflex or fear at a sudden noise in their vicinity. So we have this idea of that moral emotion response. The second category that we might think of in terms of abnormal morality would be the moral emotional level. This is probably the simplest way of looking at it. Simply you have hypermorality and you have hypermorality. So in these cases, you would have sort of normal moral emotions, but they would either be too high or too low with regard to the species' typical reaction to a particular stimulus. So this might be like hypothyroidism or Cushing's disease, which is a case in which there's too much cortisol in the body and has various sorts of physical, psychological effects. And thinking about a moral emotion response to this, it might be the case that, for example, if you were hypermoral, you might do something that would normally create a lot of guilt. Let's say that you would harm someone, but you feel very, very little guilt. Almost just a strange, not a complete absence, but a strangely low level of guilt. Or it might be the case that in response to a situation like you have the opportunity to give to charity, and you do give to charity, and you give a lot to charity. You might give more than you can really afford, and yet still you go home and you have crippling guilt over the fact that you did not give more. So just too much. The third, final type of abnormality that I've thought about is moral emotion type. And this is about the kinds of moral emotions that we might have. We're certainly familiar with the kinds of classic ones, shame, guilt, remorse, pride, that kind of stuff. But it might be the case that there could be abnormal combinations or even cross-wirings of moral emotions. An analogy to this might be synesthesia. And so that it might be the strange situation in which you believe you should give to charity, and you do, and yet you suffer guilt. Or it might be the case that you succeed at something which you think is a good thing to succeed at, and you go home, and even after you've smiled, you feel a horrible disappointment. Or you succeed or something, you fail at something, and you feel excessive pride, even though you know you failed. It might also be the case that there would be entirely novel types of moral emotions. Now, this would be very difficult to tell. As an analogy, in using touch chromacy, this is a case in which it only affects women. There's a very, very small percentage of women that have a fourth type of color detection cell in their eyes, which allows them to see something sort of between red and green. They don't have the language to describe it. We don't have the language to understand it. It doesn't harm them at all. It's very interesting. In fact, in some cases, these gives them extraordinary abilities. There are tetrachromats who can, for example, look at a river and tell you exactly what the depths are all across the river because they see reflective color levels that trichromats can't see. And they don't have the language to explain it. So it might be the case that someone could have a type of moral emotion that they can't explain. Now, this type of stuff would be very difficult to detect, but I did a little bit of Google searching through bulletin boards in which people were writing in with psychological problems that they'd not been able to find help for. I found a couple of cases in which people described what they call strange emotions that they had no terms for. Just as one example, there was a man who wrote in and said that he had this strange emotion that he could not name. It caused him to burst into tears, but with no feelings of sadness, whenever he saw sunlight at a particular angle, public libraries, or wood paneling. And he had gone to a therapist, but the therapist had made things worse because they couldn't categorize what was going on with him. So, interesting. That may not be a case of that kind of thing. Now, one of the things I want to mention about the statistical distribution stuff is that I'm not saying all of these things could happen. They're conceptually possible. Philosophers like to make charts of conceptual possibilities, and in my medical ethics classes, sometimes I'll have to X out things, and they say, well, this is physically possible in another universe, but not in ours, which is very frustrating for students sometimes. So I'm not saying that all of these things have ever happened, and I'm certainly not saying that all of these things happen evenly. In fact, the frequency is very likely to be very different for these different kinds of conditions, even if they are possible, they're just conceptually possible. It does remind me, though, of Aristotle's means. When Aristotle talks about virtue, he basically takes a particular kind of cognitive reaction to a situation, and he says the virtue is sort of the proper level of response. The vice is either having too much or too little. Classic case is bravery. Bravery is good, but the vice of too little bravery is cowardliness. The vice of too much bravery is foolhardiness. So then he points out that not everything is equally distributed or symmetrical. There are many cases in which all of our vices lie almost entirely in one direction rather than another, so much so that we don't even have names for some excesses. Sometimes we have names for them, but they're very rare. For example, there's much more likely to be the vice of pleasure addiction than the vice of pleasure avoidance. Given what we think we know about evolutionary psychology, I think that there's a good reason to think this is the case, because the adaptive benefit of certain kinds of errors and certain kinds of responses in our evolutionary history have not been symmetrical. For example, if there's a novel object in your environment, it might be a predator, it might not. The penalty for making a mistake and defining it as a non-predator when it is a predator is that you die. The penalty for defining it as a predator when it is not is just that you run away and miss out on further examination of a novel object. So it's very likely the case that for lots of our kinds of cognitions and moral emotions, we are much more likely to be sensitive in one way than another. And although I certainly haven't looked into this enough, this seems consistent with the fact that we have a wide variety and frequency of anxiety disorders, but almost all the anxiety disorders are about having too much anxiety. There are very few people whose problem is that they experience pathological levels of no anxiety. All right, so if we have this concept of normality, let's talk about disease. The easiest thing for me to do was to give you a definition of disease and to say that these moral conditions match it, and therefore, there you go, moral disease, go home. Unfortunately, that's not the way it works because the notion of disease is very ill-defined. I started looking, there's a long history in the philosophy of medicine about the definition of disease, and so we know that there are these conceptual issues, but I thought, well, let's just see what the AMA says. Well, I can't find a definition by the AMA of disease. They're perfectly willing to stand up and say that a particular thing is a disease, for example, alcoholism, but they will not tell us what is a disease such that alcoholism is that thing. And when I look at the World Health Organization, they famously produce international classification of diseases, which most public health officials and physicians across the world use. And so they're very good at telling us what the diseases are, but not what a disease is. They are good at telling us what health is. Unfortunately, what the World Health Organization itself says health is a complete and total state of well-being. And so that has caused a lot of controversy controversy about the usefulness of that, because it seems that you can have lots and lots of diseases without knowing what a disease is, and to be healthy is basically to go to heaven. That's the only sort of thing to do. So it's a disputed concept. The issues that come up are essentially, if we look at one kind of thing, we can find a paradigmatic example of a disease that doesn't match that. And so I'm not going to worry about that too much. It certainly falls into part of the debate between physical and mental. There's particularly an issue about mental illness as a type of disease. So let me just say that there's a cluster of characteristics here that are at least associated with paradigmatic cases for illnesses. So I'm going to go with those. I'm not going to have a clear definition of moral disease. If we go with these cluster of characteristics, which typically include dysfunction, distress, risk of harm, biological, something that is occurring to an individual, not a group, and it's something that is not simply a social deviation, then we can look at the concept of moral disease, seeing what abnormal things might count and might not. And from a personal health perspective, you can certainly look at the cluster of characteristics involving distress and dysfunction. From a public health perspective, you might not want to look at distress too much. For example, someone with antisocial personality disorder might not have much distress, but from a personal distress, but from a public health official perspective, it would still be a bad thing. The paradigmatic cases then, of course, tuberculosis, cancer, schizophrenia, this kind of stuff. So what is the prospect for moral disease if we just look at these paradigmatic cases and this cluster of characteristics? Well, it seems to me that moral disease is actually pretty easy to fit into this. If we think of certain types of moral abnormalities as biological dysfunctions that harm, increase risk, occur with individuals, and are not simply the result of social labeling of deviation, then moral diseases seem to, in some ways, be an easier category than mental illnesses, which the American Psychological Association is constantly fighting about. In fact, they're fighting about right now as they try to put together the DSM-5, and that dispute is spilling out everywhere. There's an old idea of moral insanity. When I look up some of these old definitions of moral insanity from the 1800s, it's very striking. Of course, I know they use language a little bit different, but they will actually say something like, moral insanity is something that medical people talk about, but the law does not yet like. And moral insanity is a deficiency of a moral organ, which results in an insensitivity to morality in the same way that the deficiency of a hearing organ results in an insensitivity to sound. So what are options? Well, we can treat these moral abnormalities. Of course, just because of these abnormality does not mean it's bad. There's lots of abnormalities that would be great. So we're looking at those that have a cluster of dysfunction and risk and so. If we treat these moral abnormalities as non-diseases, what are options? Well, some of them would be diversity and tolerance. These moral neuroatypicals, they're just neurally diverse, so we tolerate them. Maybe we have to accommodate them. So just as you might have to have ADA accommodations for a person with a particular learning handicap in your class, maybe you have to have one with a particular moral kind of handicap. It certainly would open it up for personal control and even enhancement. If we treat these moral abnormalities as diseases, then of course, standard kind of medical practice. Diagnose, treat, prevent. Enhancement can come up too in things like improving function, or perhaps creating certain kinds of inoculations of the sort that are being done to try to inoculate people against PTSD, maybe increased resilience, which is highly associated with happiness and that kind of stuff. But it seems to be no different than other kinds of enhancement issues that come with medicine. Concerns, parallel concerns. These are just two. Some people say, if we pathologize immorality, we will diminish responsibility, therefore people will get away with stuff. Another side says virtually the opposite, which is if we see immorality as something which is pathological, we give the state too much power and therefore it will control the individual. So in one case, the individual gets away with too much, in the other case, the individual will not get away with enough. Conclusions. Moral cognition. Increasingly, we know it's biological, adaptive, normal, and functional. If that's the case, it can also be biological, maladaptive, abnormal, and dysfunctional. If that's true, then it seems like the disease classification is conceptually appropriate for certain forms of moral abnormality. And if morality is a special case, I would just like to hear the exception. And that's not a challenge, that's just a request. So thank you.
Outstanding speakers, and all I can say about that is now for something completely different. I'm going to come from this from my angle, which is that I'm concerned about the ethics of the practice of the clinical neurosciences rather than neuroscience of ethics. But essentially this talk is going to be a defense of the physician, because as we heard in the previous speaker, the pediatric physician that treats children with undesirable behaviors takes a lot of flack. On one side, they say the physician is...
Jeff, can you move your mic forward? Either you step back or move your mic.
I'm stepping back. So, either the physician is doing too much, or the physician is doing too little. And I'm going to say how we got there, or got here from there, and perhaps suggest what you might try to do about it. Now, these undesirable behaviors that we're talking about are not new. I mean, their characterization has been in the literature for 150 years or more, and they really actually don't differ that much from what has been outlined in most diagnostic and statistical manuals up to the 5 that is coming up. And Heinrich Hoffmann in the 19th century really described them fairly beautifully in his very famous poems as the oppositional Struhl Peter, who said anything to, he didn't say it, people who saw him said anything to me is sweeter than to see shock-headed Peter. And of course there's fidgety Philip, who wriggled and giggled, and then I declare swung backwards and forwards and tilted his chair. And the inattentive Johnny look in the air, oh, you should have seen him shiver when they pulled him from the river. And the terrible conduct of cruel Frederick, the horrid, wicked boy was he. And we recognize these disorders in pediatric neurology and pediatrics. And they were also again described by George Frederick Still in an oration he gave to the Royal College of Physicians at the beginning of the 20th century. And Still was described as the father of English pediatrics. And he talked about these psychical conditions in children that he'd been examining. And he said the particular psychical conditions with which I propose to deal in these lectures are those which are concerned with an abnormal defect of moral control in children, which reflects what we just heard. And he said the moral control with which I would wish to consider is not only the altruistic, it's not only of a disadvantage to others, but is also the self-regarding, it's a disadvantage to the perpetrator. And he said that this defect of moral consciousness couldn't be accounted for by any fault of the environment, the biological basis. And he then went on to reflect what people are still arguing about, that these considerations on the nature of the defect may appear to be too speculative to have any practical value, but I venture to think that they do have some basis in clinical fact, and that is clear. And my reason for bringing them forward in this connection is to emphasize the possibility that other morbid conditions beside defects of moral consciousness may be responsible for defects of moral control. Again, a biological basis for behavior, perhaps a natural basis for morality. And this was a very popular theory in the 19th and early 20th century. Gall, as you know, could feel the bumps and lumps on the skull, which represented underlying lumps and bumps on the brain, which represented various vices and virtues. And thus, when you mastered this scientific skill, you could detect the morally infirm and differentiate higher from lower races. And again, in the 19th century, the father of modern criminology, Lombroso, stated that criminals were evolutionary throwbacks. They had atavistic brains, they had characteristic morphological features, they had stigmata related to the atavistic criminal. And the basic assumption is that the problem is of a biological nature, and it's this which gives rise to human behavior and character. And you can study it objectively and scientifically. Well, of course, we've come a long way since then, as you can see. And we've seen slide after slide telling us how we can feel the lumps and bumps and avenues and byways of the brain and determine the moral character of the person underneath. I mean, there is an element of truth in this. Let's not deny this. That people with conduct disorder have fairly typical functional MRIs, and those with classical attention deficit disorder will show other signals. And the nefarious amygdala will I don't know if a group of neurons can be nefarious, but I think I like to think of them that they might. Anyway, these always light up in conduct disorder, and as we heard yesterday or the day before, that you can see that there are brain regions found to be structurally or functionally impaired in antisocial, violent, and psychopathic populations. That's a bit scary. Now, I don't want to particularly talk about that, but I just want to remind us, and I'm sure you all know, about the dangers of scientific truths equating to philosophical truths. Of course, they don't. But I do want to talk about those behaviors in children that we want to change and we want to recognize. And I want to acknowledge Eric Parens and Josephine Johnson, who did the best work on this, or describe the various problems that people like me can read and understand, and I'd like to congratulate them about that. And of course, I've stolen a lot from this. But as we heard earlier, there's no doubt that there are certain individuals, young people, that we want to recognize and we want to control, as this one is here. And when I look at this picture and I think about the complaints about changing authenticity in Alex here, I think about the doctor talking to the mother of Alex and saying, you know, we can give Alex a pill, but he won't be the Alex that you know. And she says, oh, I hope so. And it's important that we do this. You know, there are groups of individuals whose behaviors are a threat to society. There's no doubt about it. And they need help for themselves, and society needs help against them. As we said, the problem is both altruistic and self-regarding. And the problem is, how do we recognize it and how do we manage it? And to what extent do we go? So how do we view these undesirable behaviors in children? Are they part of a continuum of normal behaviors? Are they different from that? Are they criterion referenced? And are they overdiagnosed and poorly managed? Well, I have a limited amount of time, so I can just say that the answer to these questions is yes. behaviors and the DSM and the controversy over the new DSM-5 that's coming out. And we can understand why there is this controversy. Here we have this august institution, Hopkins, saying that up to 1 out of every 5 children in the United States may suffer from an emotional or behavioral disorder. Disorder, not behaviors we don't like but are normal. And that's an amazing number to me, but it is for most people. And we know that this new DSM is coming out, and there's a lot of controversy about that. And here are some of the responses to this new manual from England in the British Medical Journal. And the critics claim it will make an already problematic diagnostic system worse and result in more people being labelled mentally ill. That more aspects of emotion, behaviour, cognition are going to be labelled as diagnosis, and this will medicalise more of what most people view as normal human behaviour. And they view the proposed revision, they're scared that the proposed revision will include a vast number of social, psychological and behaviour problems in the category of mental disorders, so pathologizing mild eccentricity, loneliness, shyness, sadness, and much else. And a little dig at the American system when they say the categorization of the kind proposed for DSM-5 may be more appropriate in the US, where a medical diagnosis is often necessary to qualify for reimbursement for the costs of treatment. Well, it's true. So what about this medicalization? What is it? We can just quickly say that it occurs when a lifestyle wish becomes a medical necessity. We can say when socially undesirable behaviors become a medical diagnosis requiring medical treatment. And Conrad has written a lot about what this medicalization means and its problems, and if I can just give a summary of this. It says it turns all human differences into medical problems. It gets to define what is normal, body shape, behavior, learning ability. Attention is focused on the individual and away from the social context. Medicine is viewed as a commodity, and that's definitely true and getting worse and worse. And then the consumers, rather than the patients, are then placed at risks for medications. And I'd like just to quickly respond to some of those from the physician's end. And that's just ask the question, what role does society want the physician to play? I think that had probably been worked out and decided upon them, and it really revolves around the fact, particularly with the pediatric physician, that patients, families and the state enter into this fiduciary relationship with physicians. And then the expectation is that physicians will fulfill their obligations in a virtuous manner, bearing in mind that the converse is that the states and parents and physicians all have a special fiduciary responsibility to children. I just want to quickly talk about, or very quickly mention Big Pharma and its effect on this prescription of medications for childhood behavior. And I know everybody here will be shocked, very shocked, to hear about the behaviors that Big Pharma get up to when they're selling their product. The problem is you wouldn't be shocked, of course, and that's the problem. You know what they do. You allow them to do it. And it is fairly clear that lions eat gazelles. If you want to look after the gazelles, then you have to do something about keeping them away from the lions. Big Pharma have done exceedingly well in the last several decades in pushing their nostrils And the doctors have been part of that success. And there's, in my mind, no doubt that they push and over-prescribe. But I'll say one of the reasons why that is in a minute. I think, first of all, we have to decide what do the general public expect of a physician, not what do the academics and the intellectuals expect. And I think the general public expect a physician to be a scientist, a healer, a sage, a priest, a guide, an advocate, a parent, even a parent, despite the incorrectness of saying that. They expect the physician to think like a scientist and act like a priest. They do not expect the physician, and never have, well, not in the last couple of hundred years anyway, to be a commercial purveyor of some product. Now we know the special duties that are easy to outline that we expect physicians to have, competence and humanistic skills and avoiding disproportionate harms and not lying and being faithful to their relationship. We know that. But that's all well and good if it's not founded on what the practice of clinical medicine should be founded on, which is a very strong virtue ethic. And that's that the physician is acting for the good of the patient. And the good of the patient is characterized by an action that is both right and good. Right according to medical standards, achievability, and likelihood of providing a beneficial outcome. And good according to the desirability of this benefit. That's judged by the patient's values. You can see the influence Pellegrino has on me for coming out with this statement. If I could just mention Dr. Franz again, he did outline some problems with physicians in the area that we're talking about. He talks about that there was overdiagnosis, that there was misdiagnosis, that there was underdiagnosis. And my response is somewhat new. And of course there is, and there will continue to be so. And we need to change and recognize that and ameliorate it, but not encourage it. And the situation encourages it. So what is the physician's role? Well, people argue about it. Philosophers, psychologists, bioethicists, social scientists, public intellectuals. This audience may argue about how broad the role of the physician ought to be. The parent brings their children to the physician with concerns over the behavior of the child. Doesn't bring that child to the moral philosopher. And the schools still ask for a physician's opinion and endorsement. Physicians are asked to make value judgments all the time. And in fact, the scientific and the logical approach to various clinical problems is a very small part, not a very small part, but is only a part of the practice of clinical medicine. Parents respect those judgments based on their own agenda. So how easy is it to make a careful diagnosis and institute appropriate management? The physicians need adequate training. The adequate training may be to listen to the first lecture you just heard, and defining what moral disease is, etc. The child needs multidisciplinary evaluation. There needs to be adequate time to evaluate and consider social context. There needs to be reasonable access to both pharmacological and non-pharmacological management. None of these things exist. And of course, the reimbursement and remuneration does depend on this PSN diagnosis, and it depends on the number of patients seen. So, just quickly, despite all this, there is increasing pressure for increased pressure to prescribe. Busy physicians are influenced by their own self-interest. They need to see more patients to make more money, and they can see more patients if they just write prescriptions rather than arrange behavior modification plus prescriptions, etc. They're heavily influenced by Big Pharma through attractive reps, through pharma-sponsored research and education. The parents are influenced by the school. Please put your child on a plan. They're influenced by the family history. He's going to turn out just like his father. And they're influenced by home and socio-economic situations. And of course, particularly in the United States, they're influenced by media marketing. Ask your doctor if soda is right for you. And there's this increasing desire to have supermarket and fast food medicine. Would you like fries with that type of medicine? And so, what are the influences that we can't control? It instills defects of moral control, which is what we're talking about. Well, first of all, I'd say there's a very broad, heterogeneous differential diagnosis to these so-called disorders of moral control. We were hearing about earlier about sadness without feeling, and crying without feeling, laughing without humor. These have all been identified, and they need to be neuroanatomical correlates have been identified, and they need expert diagnosis and differential diagnosis. That requires adequate training facilities, multidisciplinary evaluation. However, the pressure on that is that people want individual freedom. They want to be able to go to anybody at any time and demand what they think is right, particularly to either control or enhance their children. And society's freedoms also allow practices that increase these undesirable behaviors. And we have to realize that if we want to do something about that. For example, artificial reproductive technology increases twin pregnancies and prematurity, which increases autistic-like behaviors and disorders of attention and vigilance. You can make, okay, let's get rid of ART and we'll have less of that. Nobody's going to do that. And of course, even greater influence is that we tolerate social injustices. The socioeconomic pressures that I mentioned. And then the other influences are, of course, political. And I'd like to finish off again quoting Eric Parent and Johnson. But too often in the US, diagnostic and treatment decisions are driven and constrained by the broad culture and institutions and systems in which parents, children, and clinicians must operate. In the final analysis, this is a matter of political philosophy. It's a matter of political will and societal choice. And I'll finish that.
So our last presentation in this set is coming from our host, just to repeat for somebody who may not have been here invested in that, he's the Associate Director of the Center for Bioethics and Clinical Associate Professor of Bioethics and Further Professor of Philosophy right here at NYU. And Matthew is going to take us in depth into the oxytocin of
So I'm going to talk about parental love pills. It seems appropriate to talk about this because we've been talking about moral enhancement, and it seems like it'd be good. That's sort of quite general, and this might be a specific instance of a specific application. And from this, maybe we can learn something about what it means to enhance morally. So there are a lot of studies that show that it'll be obvious to you that children need to be loved. But there are also a lot of studies that suggest this. So for example, studies of children in institutions, going all the way back to Bernays, showing that these children who are orphans, who live in institutions, they become ill more frequently. Their learning capacities are not as good as sort of compared to other children. They become increasingly interested in their environment as they stay there longer. They don't thrive. They were constantly depressed, and they eventually developed severe learning disabilities. There are also studies of monkeys in laboratories that are sort of more controlled, and they show also same thing, hampered social, cognitive, and emotional development. And more recently, there are a number of neuroscientific studies that show that the lack of love, or sort of what can be sort of equivalent to lack of love, can dysregulate the development of the brain neurotransmitter systems, such as the norepinephrine, dopamine system, and the serotonin, which Molly talked about, cause the development of adrenoglucocorticoid responses to be modified in very negative ways, and affect the biochemical processes of the growth hormone secretion leading to psychosocial dwarfism. And so elsewhere, I've argued that because of this, because of children's need for love, they have a right to be loved, and we have a duty to love them. Today, what I want to talk about is sort of explore the idea of whether maybe we can pharmacologically induce parental love. And there's some evidence that maybe we can start to begin to do that. And we heard about this magical wonder drug already. So affiliate behavior such as parental infant pair bonding, maybe it's possible to induce it pharmacologically through oxytocin, which has been implicated in this process. So oxytocin is produced by the neurons of the hypothalamus, and it's released from the axon terminals in the pituitary gland into the bloodstream, where it stimulates the uterine contraction and milk ejection. This plays a role in initiating maternal behavior, and in addition, oxytocin is also secreted into the brain of males and females from the hypothalamic neurons to the limbic sites, including the hippocampus, the amygdala, the striatum, and nuclei in the mid and high brain. And a number of animal studies have suggested the association between oxytocin and affiliative behavior such as parent-infant pair bondings. So just to give you a few examples, female nudibranchs rats typically find pups to be aversive and actively avoid them. But when you give them oxytocin, this facilitates maternal behavior in these rats. Conversely, if you inject some sort of oxytocin antagonist, this inhibits this initiation, but not the maintenance of the maternal behavior in these rats. So that's quite interesting. Also, the time spent by the female prairie voles crouching over juvenile pups was positively correlated with the density of the oxytocin receptor binding in the nucleus accumbens in the juvenile pups. And injecting oxytocin antagonists in the nucleus accumbens block the maternal behavior. One other data, so sheep typically display selective maternal care, but when you give them oxytocin, this facilitates the acceptance of a foreign lamb, even in non-pregnant sheep. So there's actually sort of animal models of this already. In human beings, oxytocin has been associated with bonding-related factors such as empathy, closeness, and trust. So, for example, intranasally administered oxytocin was shown significantly to promote trust among male volunteers playing the alternating game. The effects, in that study, the effects of the oxytocin were not due simply to an increase in willingness to engage in risky behavior, but rather they were due to the participants' willingness to accept social risks. And also, birth, another example, following birth, mother-infant touch and contact stimulate oxytocin release, and early parental neglect has been found to alter this release. So taken together, these studies suggests that exogenously administered oxytocin can initiate affiliative behavior, possibly by decreasing anxiety and promoting trust and pro-social behavior. We need to do a lot more research, but there's some evidence of this. So as a philosopher, now I want to go hypothetical and think about what it means if we could come up with a pill, sort of the possibility of parental love pills. Now, I think there might be a status quo bias against pills. Whenever we talk about pills, people think that, oh, it's medication, etc., etc. So just think, what if we put it in liquid form? So the parental love potion. Just think about that. So as a philosopher, I'm going to set aside issues about safety and justice, research ethics, things about informed consent, etc., etc. I'm also going to set aside relational uses, basically all the problems all the real problems. And I'm just going to focus on personal uses. And I want to sort of consider just on personal uses where there's still remaining ethical issues. And I want to suggest that there may be some, but they're not as serious as we think they are. And this work is drawn on something that David Wasserman and I have worked on in a different paper. So it's sort of an application of something more general that David and I have worked on. Okay, so can parental love be induced? First, let me just give you a really quick working definition of what it means for parental love. You'll be thinking to yourself, what does he mean by love? So here's a definition. To love a child is to seek a highly intense interaction with a child, where one values the child for the child's sake, where one seeks to bring about and maintain physical and psychological proximity with the child, where one seeks to promote the child's well-being for the child's sake, and where one desires that the child reciprocate, or at least is responsive to one's love. I'm not going to be able to defend that account here, but what I wanted you to notice is that this is a complex of behavior, attitudes, and emotions. So the behavioral aspect is sort of seeking to bring about physical and psychological proximity, and the attitudinal aspects include valuing the child for the child's sake, and the emotional aspect is sort of this highly intensive aspect of this condition. Okay. And I think we have already, I just want to sort of, and this is another work that I've done, I'm actually trying to write a book on this. We already have a variety of ways, before I talk about pharmacological question, I just want to mention that we already have a variety of ways of inducing parental love, both direct and indirect means. So for example, and whereby we can bring about parental love with success. So here, operationally, I'm defining parental love in terms of warmth and affection. And I think there are a number of ways that we can do that. So for example, we can give ourselves reasons, internal reasons. And that can get us, when we give ourselves reasons, that would make us more likely to feel love for a particular child. And one such reason is, you might just say, look, the child needs to be loved, and that's a pretty good reason for why you should love your child. Another thing we can do is something what I call external control. So that's where you put yourself in conditions where you're much more likely to feel that love for the child. So for example, if you know that getting enough sleep helps you to be more affectionate and warm towards the child, then you might try to make sure that you get enough sleep, if that's possible. You should have so that you will be more loving towards the child. My wife's pregnant, we have a baby coming up in 4 weeks, so good luck to me. More than my wife. And finally, that came out. Okay, and finally, there's cultivation, right? So this is sort of when you go through the process, this Aristotelian type cultivation, where you repeatedly give yourself internal reasons, but also external, put yourself in the right kind of position, and slowly you become habituated and you're disposed to love the child for the right reasons and the right conditions. So there are already these sort of low-tech ways of inducing parental love. Okay, So before I talk about, so why would anyone want to take a parental love pill, you might ask? There are occasions when one wants to love a child, but for various reasons, one finds oneself unable to love a child. Let's just give you a few examples. So it's a common parenting experience that rather than feeling spontaneous love for their newborn, parents feel instead estrangement and resentment towards their child. So, people tend to think that, oh, the child's born, we're going to immediately spontaneously love the child. That's not quite true. Some people don't have that spontaneous feeling. And we need to acknowledge that. We can't just pretend that people always just will naturally love the child. Another thing is that, take like stepchildren. Someone might really try really hard to love a stepchild or an adopted child, but might find it nevertheless quite difficult to do so. And in these circumstances, it can be really frustrating and isolating and embarrassing not to exhibit the kind of love that children need and that you're required to provide, given the circumstance. So you might think that in those circumstances, so this is a very constrained circumstance now, if parental love pills or love potions were available, some might really welcome the opportunity to give the kind of love that children need and expect, that's expected, okay? So now I want to talk about some of the concerns that you might have regarding having such a parental love pill. And one thing that's been mentioned is authenticity, and this, rightly so, comes up. But just a couple things here. First of all, you don't want to say that authentic parental love pill must be spontaneous. Because if that's true, then that would rule out more familiar methods of what I was talking about, sort of internal, external control. Because there, in those cases, it's not spontaneous. You're sort of giving yourself reasons, and you're sort of putting yourself in conditions to love the child. So spontaneity, I think, is too strong as a condition for authenticity. So another thing is that to think about in terms of authenticity, there are actually a bunch of related notions around authenticity. And what I'm going to do is try to unpack some of them. So you might, one thing is that you might worry that induced parental love might not behave like real parental love. So call this the experiential authenticity. So if you sort of took a pill and this sort of made you love every child you see, that wouldn't work very well, right? So to address this problem, I think this is kind of a technical problem, really, rather than an ethical one. What you need is you need to make sure that the drug fulfills certain success conditions. So, for example, you have to be able to turn it off when you need to, or when you want to. Also, another thing is you might find the case that you can have concurrent emotions. So while you're feeling love for the child, you can also feel anger towards the child, right? At the same time, it shouldn't sort of, when you have this sort of emotion, it shouldn't block you from having other emotions that are maybe appropriate. So sometimes, you might love your child, and if she does something bad, you might feel anger towards her and sort of upset, or at least be upset with her as well. The intensity should vary. So as I said, if you had sort of deep love for a total stranger as child as for your child, then there's something wrong with that. Whoops, sorry. So another thing about authenticity, which is related to the notion of authenticity, is actually this idea of ownership. And the idea here is something like, it's akin to Frankfurt's notion of identification. So Harry Frankfurt has this idea that for one to be morally responsible for an action, the desire behind it must be one which you identify. So for Frankfurt, this means that the desire must be endorsed by some sort of high-order desire. So you desire that, you desire X. But attempts to induce parental love pharmacologically, so you might worry about that, sort of whether you would really own that particular emotion or that particular desire to love the child. But here, it's worth remembering that attempts to induce parental love pharmacologically will usually be accompanied with consonant beliefs. Often it's because we believe that parental love to be warranted, if not required, that we seek to induce it. So in such circumstances, a pill may be able to stimulate the type of emotions and behaviors and attitudes that would have ordinarily accompanied the belief. And finally, I'll talk about another related concept, which is self-alienation. So this is the idea that's sort of being talked about. Is the pill going to make you, it's going to turn you into a different narrative person, completely, in a narrative sense, rather than in a numerical identity sense. And here, I think we just have to acknowledge that it seems that it's possible that parental love pills could do that. But as the previous speaker said, as Jeff said, that if it turns out that they do, I think one thing we have to do is we have to let people know of the side effects. But on the other hand, a person might want to take such a pill voluntarily, fully aware of its personality changing effects. And so in this case, I think this concern with alienation becomes less acute. And so here, I'm inclined to think that if the person is aware of the problem, there's no right reason why he shouldn't be allowed to, choose to fashion himself into someone who's loving towards children if that's what he really desires. So another thing to think about is whether another moral concern is that you might think, so in sound sentiment, David Kretschmar argues that emotion becomes narcissistic when the focus shifts from its object to its subjective experience. So you might think that deliberately inducing parental love is going to cause you to focus on your subjective experience rather than the object, namely the child. You're sort of thinking, am I loving the child rather than focusing on the child? And so you might think that it's sort of become narcissistic. And I think this concern should be taken seriously. If the parent talks exclusively about how he feels, and what his attitudes are towards the child rather than what the child needs, then this seems like something has gone wrong. But at the same time, the claim can be overstated because if the parent took a pill to increase her sensitivity without attempting to increase her involvement in her children's life, then of course her effort might seem cosmetic. But if she took the pill to deepen this relationship, right? So take the parent with the stepchild, to deepen that relationship, then this seems that it could be acceptable. We can talk more about that. Let me just run over two other concerns. So another thing that's been coming up in the discussion is that, well, we might be sort of instrumentalizing ourselves. So we're not really treating ourselves, we're just sort of taking this pill without, and sort of treating ourselves as mere means towards sort of getting us to love the child. And this, again, if I took such a pill, parental love pill, without even thinking about whether it's the right course of action for me, then I may indeed be instrumentalizing myself by bypassing my beliefs and values. But if I took the pill after sort of careful consideration and examination, it seems like I would have treated myself as a net. So I'll leave it at that. So finally, the duty to love. If we, right now, because the pill doesn't exist, then maybe we can be excused, right? This is the eye scan problem, we can be excused. But now, once you have the pill, maybe you're obligated to take the pill. And in this context, the two things I want to say are the following. So first, we just have to remember that, there's still low-tech means. Just because you need to love the child doesn't mean that immediately you have to take a pill. There are also things that are suggested, all these low-tech ways that can get you to love a child. In the circumstance where you tried all those techniques and you can't get yourself to love the child, maybe it seems like, at least for me, it would be permissible for you to take the pill if the pill would work. And maybe it would be required if the alternative is that the child's not going to be loved and there's serious harm are going to result from that. So just to conclude, I think it may soon be possible to develop pills that induce parents to exhibit more loving behavior, attitudes, and emotions to their children. I think that pharmacologically induced love can satisfy reasonable conditions for authenticity. They don't need to cause self-alienation or promote narcissism or result in self-instrumentalization. And just one comment on Eric. I don't know what Eric thinks about this, but this seems to be a case where you're not just maintaining love. In some of the cases, you may be creating love, right, in these cases. So, and I just wonder what you thought about this. So, in some cases, there's not the love there, like you try as hard as you can, just don't love this child, and you might have to create it. And sometimes maybe it's okay to create, and rather, I mean, I certainly agree in cases where you're trying to maintain a relationship. That's okay.